I'm Dr. Padma Gunratna. What I would be doing is I'd be talking to you over next hour or so on management of stroke and TIA. These are the objectives now. These are the objectives that has been provided by the faculty for your lecture. We would be taking up a case scenario, and then we will be defining the stroke and TIA, pathophysiology of stroke and TIA, clinical presentation, and so on. So we'll just move on. These are the objectives. So just let me take up this important topic. We need to discuss stroke as an important topic, because if you know a stroke, that all of you probably have had a personal experience, either your mother, grandmother, or a close relative, or a grandparents. One of everyone generally have had a stroke, because it's such a common thing. All over the world, that leading cause of deaths are cardiovascular diseases, and then a stroke is one of the cardiovascular diseases. Heart attacks lead the list of cardiovascular diseases for global mortality, and stroke becomes just second to heart attack. So it's a leading cause of death, and it is the leading cause of disability in adults. Therefore, it is an important topic that all need to be familiar with when you get through as you obtain your qualification as MBBS. Right, so just let me take you through this case scenario. The case scenario is that this actually is a genuine case that I came across around 2004 or 5 at the National Hospital. He was 48 years. This patient had come to hospital, and he had been kept in the hospital for about 4 days, and then he was discharged, and then he now appeared to my private channel center with a channel consultation. So he is a person who has come and then left the hospital and now coming to consult a doctor. So he was 48 years. He had history of high blood pressure. He had diabetes for 4 years. He presented with sudden onset of right hemiparesis for 5 days, and he had difficulty in swallowing, what we call dysphagia, and then there was a nasogastric tube in situ. He had a speech disturbance, dysphasia. We need to know what dysphasia is, and there was a catheter in situ. And then his GCS was 15. He was conscious, rational. This is a man who was a breadwinner of the family, a sort of proud father who was earning for the family. And every day he went for his office and returned back home. He walked very smart, and all of a sudden everything happened. As he got up in the morning, he was all right, but then he got dressed up, and then he left home, and then was in the bus stand waiting for the bus, and he saw bus coming, but then he just could not get into the bus because that his half of the body went paralyzed. So but then he was conscious, rational. He knew that he was brought to a doctor outside, and he indicated he wished to die, because that he did not want to wait, to live with that paralysis. He could not speak much, but then he indicated that he had no desire of continuing with his life. His blood pressure was 160/80, and when I checked his heart was irregular. And the ECG indicated that he had atrial fibrillation. Now, if this is the clinical history that you come across as the medical officer, now because that we are going to discuss stroke, you know that this patient also suffered a stroke. Could any of you tell me that how do you decide that this patient had a stroke but nothing else? Is there a way for me to get an answer? Is there anyone who would be willing to communicate?
Madam, is it by CT scan?
Anyone else that who would like to let me know that how you would know?
In the history, this is an incident of a sudden onset, and patient has right hemiparesis, suggesting an event in the brain.
Anyone else? Any other answers? There are 160 standing in chat. Right. The now actually, how you know is that by the history. So it is by the history. Any of you, this is the person. Sorry. You see, he is still alive. Now this happened. I told you that this is a genuine story, and this happened in 2000, around 2004. Right. So he is still alive. How you say that he had a stroke is by taking the history. Now, you know that if you have a brain problem, I mean, there are few reasons why you may get a brain pathology. It may be a neoplastic, like say tumor somewhere, and then you may get either primary tumor or it may metastasize. Sometimes it may be an abscess. So there is an infection. It could be pathogenic or it could be tuberculoma. Sometimes it may be a demyelination. Sometimes it could be vascular. So vascular could be either one of your blood vessels all of a sudden get blocked, or one of the vessels might all of a sudden rupture and bleed into brain. So in either case, if it's vascular, I mean, if you compare these 4 case scenarios that I discussed, you know that vascular is all of a sudden. So it is from the history that we decide that this patient developed a stroke, but nothing else. So here is a person who was in perfect good health, all of a sudden developed symptoms. So that is the very characteristic feature that is important for you to arrive at the diagnosis of the stroke. That fact that one should be able to elicit, if otherwise paralysis of one side, speech difference, visual disturbance, they all could occur in any of the other etiologies that I described. Therefore, if you want to diagnose vascular all the time, you have to elicit the fact that in the history that it was sudden onset. That becomes more reliable than many other investigations, because say if you get the CT, say you know that in case of stroke, 85% of strokes happen because of infarctions, and it's only about 15% of strokes happen because of hemorrhages. So if you suspect one to have an infarction, then you are more likely to become correct, because many of them, they develop infarctions. But if you try to diagnose infarctions by if you try to diagnose a stroke by doing a CT scan, CT might give false positives as well as false negatives. I'll let you know how it causes false positives and false negatives. But it could cause false positives as well as false negatives. So the most reliable way for you to diagnose a stroke is by taking a history and eliciting the fact that it was sudden in onset. And how do you elicit that it is sudden in onset in the history? Is by asking the person, what did you do at the time you developed symptoms? Say, if I could say that I got up today morning and I left home for work, and then halfway while I'm doing ward round that I developed symptoms, that clearly indicate that the symptoms were sudden onset, isn't it? So generally, in case of sudden onset, one could indicate what patient was doing at the time that they developed symptoms. So if you could ask, how were you half an hour before that? Say if half an hour before that, then if patient would say that it's all right, then you could ask, what did you do that once you develop symptoms? So more often patient would say that I stopped work immediately, and the person will not be able to continue with whatever he had been attending. So by eliciting that history, generally you could arrive at the diagnosis of stroke. So this is the CT scan. Now here is a man Now, generally, this is the practical thing that I'm telling you. Now, in Sri Lanka, generally, when you get a stroke, our teaching is for to reach a hospital that is with a CT scanner as early as possible. CT scan is like ECG. Now, if you all have done your lectures for ischemic heart disease, now we do not do it manage ischemic heart disease without an ECG in medical profession. No. I mean, we just need that basic investigation to manage the ischemic heart disease. So CT scan is the equivalent of ECG to myocardial infarction. Without a CT scan, it's not possible for us to diagnose a stroke. So therefore, we say that, I mean, there are very urgent things that you need to that you could do in case of stroke. And here the patient has gone totally paralyzed. And in Sri Lanka, all patients, I mean, when they arrive hospitals, all patients are transferred to places where the CTs are available. So the CT scans are done in 99% of strokes in Sri Lanka. So now if you do CT scan, this is how the CT would appear. And we do first CT scan, and more often because of the problems with resources, we do not do a repeat CT scan. So more often when patients are discharged in about 4 or 5 days, they come with this type of a CT scan, but the person is totally paralyzed. And do you see any abnormality in this CT scan? This CT scan is normal. So the reason why the CT scan is normal is because in case of infarctions take time to appear on the CT scan. So I told you that 85% of stroke patients, they develop infarctions, and infarctions take time to appear on the CT scan. So more often when you do the CT is normal. So this is a false negative, isn't it? Right? You have a pathology, patient is with a pathology in the brain, but the CT is normal, and the CT takes time to appear changes of cerebral infarctions. Whereas the CT is very sensitive in picking up hemorrhages. Hemorrhages would appear, I'll show you in a little while, the CT with hemorrhage. Hemorrhage would appear immediately following a CT scan. In a CT scan. So why you do CT scan? You do the CT scan to differentiate hemorrhage from an infarction. It is not to diagnose the stroke. It's from the history that you have diagnosed the stroke, but you differentiate hemorrhage from an infarction by doing a CT scan. So when CT is normal, then we know that this patient had an ischemic stroke. So this is the CT scan of that patient. And this is someone else's CT scan actually, but this is how it was about 12 hours afterwards. Now you see that we are lucky that we have two sides. Now this is appearing little hypodense. This is how it would appear in about over the next 12 hours. And then much later, it becomes very much like this. The words that we use to describe CT is density. This is hyperdense, and this is hypodense. Do you see my cursor?
Yes, madam.
Yes. So this also is hypodense, right? So little by little, when it becomes an old infarct, that would appear very much hypodense. This is the word that we use to describe black in hypodense. So what is a stroke? Now before that, so if we get back to, it's easy to discuss in this clinical scenario. Now, if you get this person, he is 48 years, he has diabetes for a very long period, which is a risk factor for stroke, and then the high blood pressure is a risk factor for stroke, and he developed right hemiparesis. So as you develop right hemiparesis, you know that your right side is the dominant side, isn't it? So along with that, your speech area also is in the left hemisphere. And speech area is not in the internal capsule, it's not in the basal ganglia, but in the cortex. So as you say this word dysphasia, now speech disturbances is something that you need to develop the skills in recognizing. So there are three forms of speech disturbances. Those are dysarthria, dysphasia, and dysphonia. Now, if I say, if any of us develop a sore throat, our articulation of words are all right, the grammar, the contents of the speech is all right, but there's a problem of producing the sound So we would say like sort of, I mean, it's not the sound that appears. The pronunciation, everything is fine. So in that type of a situation, you call it dysphonia. Whereas if you are with a problem in articulation, say if you are with a bitten tongue, or if you are wearing ill-fitting denture, or if you are with a cerebellar pathology, I mean, cerebellum is the other important structure in the brain that is important for us to coordinate movements. So for me to talk like that, there are many muscles that need to be coordinated, isn't it? So that if that coordination is lost, my grammar would be all right. But there would be a problem in pronunciation or articulation of words. So in that type of a situation, we call it dysarthria. Whereas if I say dysphasia, then I admit that this patient has a pathology in the speech area of the brain. So and as I say dysphasia, I have located the pathology. So when we see a neurological problem, all the time you know that we have two interests. One is to locate the pathology. The second is to find out what the etiology is. So I told you the etiology is from that history sudden onset. And as I say dysphasia, then I have located pathology. I know that it's the dominant hemisphere, and I know that it is in the cortex because speech area is in the cortex. And there you have the receptive area for you to understand the speech, or Wernicke's area, and the expressive area or motor area or Broca's area for you to express yourself. And if both are affected, you call the global dysphasia. So the person who has receptive dysphasia, they would not understand what you are talking. Say if you ask the patient to close eyes, lift the right hand, then he will not give you a proper answer. But if you just show him with gestures, because the patient is conscious, rational, patient knows that you are the doctor. So if you show with gestures, then he would read the gesture, he would do that. He would raise the hand. But whereas if you stop gestures and just use words and say that raise hand, patient would won't do it because there is receptive dysphasia. Whereas the one with expressive dysphasia, they would understand what you say. So if you ask the person something to do, he would do. But if you ask a person for which that you express a verbal response, then he would find difficult to express himself. Just if you say that I just describe your symptoms, then he might talk some nonsense and you might label the patient as confused, but he is not confused. He has difficulty in expressing himself. Say the one form of dysphasia that you see is nominal dysphasia. I mean, that also is a form of expressive dysphasia. So sometimes if you ask the patient, if you show the patient a pen and ask what this is, now he will not be able to name that because he has forgotten the name of that pen. He would say that this is what is used for writing. Or if otherwise, if you suggest the patient, if you ask the patient, is this a ruler? Then patient would say, no, it is not a ruler. Is this a cup? Then patient would say, no, it is not a cup. But if this is a pen, then patient would say, yes, it is a pen. So by eliciting all these phenomena, the nominal dysphasia, global dysphasia, receptive dysphasia, expressive dysphasia, then you locate the pathology and you know that then the speech area of the brain is affected. So, and then dysphagia, I have told that it's difficulty in swallowing. And in this patient has atrial fibrillation. So as there is atrial fibrillation, then you know that there is cardioembolism. They are in the high risk category for cardioembolism, and those are important entities for us to elicit, because if you are with only high blood pressure and diabetes, then you have long-term risk factors for cardiovascular disease, and more often high blood pressure and diabetes would cause the small vessel disease. The capillaries would undergo the changes owing to that long-standing high blood pressure. Whereas as you say cardioembolism, then what they develop is the consequences of large emboli. So in atrial fibrillation and cardioembolism, you get large emboli and they block large vessels. So all these are important facts for me for clinical evaluation of this patient. So we'll now move on to the topic. Right. So now what is the definition of a stroke? Definition is a rapidly developing clinical symptom and of focal or global disturbance of cerebral function with symptoms lasting 24 hours or longer or leading to death with no apparent cause other than of vascular origin. So this was this time duration 24 hours or less than 24 hours is for places, I mean, is what is being used, what we used previously, but now this is little change because say if the patient, you know what infarction is, what ischemia is. So if I say cerebral infarction, I mean, you know that ischemia is reversible. I mean, the brain cells are ischemic, but still viable. So if you immediately open up the vessel, those cells are still viable and they return back to normal. Whereas if I say infarction, the cells are dead and gone. I mean, they are not no more viable. So if I say stroke is a cerebral infarction, then you can't define based on this 24 hours term. Problem had been because with the now we were talking in terms of CT scans. The CT is not it has become a crude investigation, and it is not a sort of a fairly sensitive investigation to differentiate infarctions from ischemia. Therefore, whereas MRIs do differentiate infarctions from ischemia, and so if sorry, if we could if MRIs are available everywhere, then we could define, we could practically use the definition based on infarction and ischemia. But in our clinical day-to-day practice, because the CTs does not differentiate infarctions and ischemia reliably, you make use of this old definition that is that has been defined based on this time factor. But in general, it has to be with the MRI, and we should be able to differentiate ischemia and infarction, and then based on that we say whether the patient had an ischemia or infarction. So stroke is an infarction, pathology, cerebral injury that has caused either by an occlusion of a blood vessel or by rupture of a blood vessel, and in either case it is vascular in origin and there is focal or global disturbance of cerebral function secondary to an insult to cerebral cells. Then it's if symptoms lasting less than 24 hours, then we call that as transient ischemic attack. So I told you that in case of transient ischemia, now I'm again telling you ischemia and infarction. In case of stroke, there is death leading to death, cell death. Whereas in case of ischemia, the patients develop symptoms and then they improve. So now if patient may develop hemiparesis and then it would be there for symptoms may be there for about 1 hour and then they completely improve. How do they completely improve? Either the blood clot or the thrombus that block the vessel tend to get dissolved and the blood supply to that area is restored, or the collaterals open up. By some means, the cells, the circulation is restored, the patient's symptoms improve. So when previously, say when we were students, I mean, generally consultants do ward rounds once in 24 hours. So when you come today, the symptoms are there. By next day, when consultants came, the symptoms have resolved. So in that type of situation, we thought that the patient, I mean, there were no infarcted cells in the brain. Patient has completely resolved. So those were described as attacks of transient ischemic attacks. But now with advanced technology like MRIs, we know that if symptoms lasted more than 24 hours, if symptoms lasted even more than an hour, those patients are left with infarcted cells, though they completely improve. So therefore, nowadays, it is important to have a MRI and with special resolutions that helps us to differentiate infarction from ischemia to diagnose a transient ischemic attack. So in general, if you are not using MRIs, then you could say is a transient ischemic attack if symptoms settle within 24 hours. But generally, many weaknesses that have improved, that have lasted more than 1 hour, are left with infarcted cells. They actually are strokes, though they have improved within 24 hours. So now the present definition for transient ischemic attack is a transient episode of neurological dysfunction caused by focal brain, spinal cord, or retinal ischemia without acute infarction. So for you to confirm that there is no acute infarction, then you have to have a MRI and confirm that there is no infarcted cerebral cells. So this is the pathophysiology of atherosclerosis. You see that in children, when you were born, the blood vessels are very smooth. There is, inner part is very smooth, and there is elasticity of the blood vessels. They contract and dilate. That is why we could maintain our autoregulation, and that's why with the change in posture that we could maintain our blood pressure. And with the aging, based on many factors that are modifiable and non-modifiable, these blood vessels, they go on changing, and there would be this subendothelial deposition of fat. Along with that, there will be rupture, the damage to the loss of intimal continuity, and along with that, the blood vessels become thickened, and as they become thickened, the elasticity is lost, and when the elasticity is lost, the blood pressure inside, because that it is the distensibility is disturbed, the pressure within the intravascular compartment would rise, and along with this rise in pressure, this would further be damaged, and there will be deposition of platelets and fibrins, on which that there would be deposition of red blood cells, so that there will be a thrombus formation. All this happen inside our blood vessels, and we tend to imagine that we are healthy because we just do not know why, this process until this happens. On one fine day, one of these pieces might get dislodged and could float forward along the bloodstream and could block one of the distal vessels, in which case we call it thromboembolism, or there could be thrombosis in situ, and that could be the reason for development of stroke. So these are the reasons for development of stroke in 85% of patients, and we call it atherosclerosis and thrombosis or thromboembolism. And so in case of brain attack, it is the same concept that I am trying to show you, and it could either come from the carotids or any of the large vessels and could occlude one of your vessels, or the clot could arise from the heart, and then it would block the vessel, and corresponding area, the area that is supplied by that blood vessel will get disturbed, so that based on what the area of the brain that is affected, it would determine what symptoms to be caused by that stroke. So this is thromboembolism or cardioembolism. And in addition to that, in about 15% of patients, they get bleeding into brain. Why do they bleed into brain? The first, second, third, the most important risk factor is high blood pressure. The reason for high blood pressure is atherosclerosis, and the thickened blood vessels are unable to stretch, and with rise in pressure, the blood vessels become difficult to withstand that rise in pressure, and one fine day it ruptures and then bleeds into brain. And as they bleed into brain, there is two reasons why the brain cells could be damaged. One is the blood that has bled acts as a space occupying lesion, and another is that this is an artery that has ruptured, and the artery flow is with a pressure. So there is a pressure effect of there is a gush of blood with a pressure effect, and that pressure effect also damages cerebral tissues. So the hypertension, high blood pressure related hemorrhages happen more often in these deep-seated, basal ganglia and deep-seated structures, and it's more often the small vessels that rupture, whereas if it's aneurysm or artery venous malformation, more often the bleeding would be in these peripheries or in cortices, so that if there's cortical hemorrhage, we are a little bit more careful to exclude a vascular pathology. So pathological classification, I'm repeating the same: infarctions and hemorrhages. Infarctions could happen for several reasons. It could be large artery atherosclerosis, or it could be small artery disease like capillaries, I told you, or when in small arteries, when you have been high blood pressure for a very long period, then the blood vessels undergo the pathological change called lipohyalurolysis, and these blood vessels tend to get blocked, and you may get tiny little infarcts. So those are called lacunar infarcts, and this is small artery disease. Or it could be cardioembolism. And then hemorrhages, it could be mostly because of high blood pressure. Occasionally, there are other reasons for high hemorrhages. It could be that the patient is with artery venous malformation, aneurysm, amyloid angiopathy, use of anticoagulants, cocaine abuse. They all are possible causes for hemorrhages. Right. So the epidemiology, now it's important that you have some knowledge, and the stroke could occur at any age. Generally, the prevalence tend to rise with the aging, but one has to keep in mind, even here in Sri Lanka, 30% of stroke happen in people less than 60 years of age. At an age that they are still in a productive age. There are many reasons why they develop it, and many strokes, about 80% of strokes could be prevented, particularly the strokes in young people. Some tend to carry the impression that strokes happen only in old people, but keep in mind that stroke happens, 30% of stroke happen in people less than 60 years of age. And it's the fifth leading cause of death for people between 15 to 60 years of age. Incidence rises exponentially with age, and it is more in men, higher incidence in lower socioeconomic group, and more than 80% in developing countries. Out of the world's stroke burden, 80% occur in developed countries, mainly because many strokes could be prevented by controlling the risk factors and by controlling basically it's the risk factors. So it's an important area that all have to pay attention, because it may affect even when people become disabled at very young age, it may affect even an economy of a country. So the clinical presentation of stroke and TIA. Now, based on where your pathology is, the symptoms are going to be determined. But there are few syndromes that we encounter more often in our day-to-day clinical practice. Now, what are those syndromes? One is that the patient may develop hemiparesis. That's the most common clinical feature, isn't it? So we all may have encountered. So it may be face, arm, leg weakness, or sometimes it may be face and arm weakness. Sometimes it may be arm and leg weakness. Sometimes it may be only face involvement. So it is hemiparesis is the most common symptom. And it's not uncommon to develop hemianesthesia. Half of the body may become benumb. So the housewife might say that I started preparing the tea, and half of the way that my whole body, half of this side went benumb, and then I stop, and since then I'm left with numbness of this half of my body. So you know that it is a stroke, and probably on the contralateral hemisphere, and it's not in the hemisphere, it's in more often in the thalamus. So that is another symptom that you may encounter. And another important symptom is the speech. Now I told you this, if the cortex speech area of the brain is affected, so all of a sudden one may be left with dysphasia, or if it's a brainstem stroke or a cerebellum stroke, then patient could be left with dysarthria. And then the vision. Now vision is another important area that you should develop skills in evaluating. In case of vision, now you know that the only branch that you get from the internal carotid artery is the ophthalmic artery that supply the retina, the eye. So if you are with the occlusion of the if you are with thromboembolism to ophthalmic artery, then you could be left with loss of vision, sudden loss of vision of one eye. The retinal artery may get occluded, and so that you may lose vision of one eye. So that is maybe one way that one may present with a stroke. So if you lose vision all of a sudden, that is related to atherosclerosis, and that patient need to be evaluated like in case of a stroke. That's an important area because more often people tend to end up with eye surgeon, and then they go on treating the eye, but then they do not know that the reason, they have not been evaluated adequately until they lose the vision of the other eye as well. So that is one way that vision, the symptoms of vision may appear in case of stroke. Or if otherwise, then you know that your visual pathway, if you could remember, you have your optic nerve, and then the medial fibers cross at the optic chiasma, and then you have optic tract, optic radiation, and they end up in the occipital cortex. So any pathology posterior to the optic chiasma would cause contralateral homonymous hemianopia. So now if you are with a stroke in the internal capsule, or if you are in the stroke involving the parietal or temporal cortex, or if you are with the stroke involving occipital cortex, in either of situations, you could be left with contralateral homonymous hemianopia. So as problem presentation could be with the vision disturbance. When you examine, you might see that that patient has homonymous hemianopia. So how would you elicit homonymous hemianopia is that say when you are looking straight, and we are not looking on either side, when you are looking straight, our visual fields are 180 degrees. So the students who are seated on my left side, I see them with my right hemisphere. So whether I close my left eye or whether I close my right eye, I still see them with the right hemisphere. So if I'm with a stroke on the right hemisphere, I will not see, while I'm looking at straight, I will not see students who are seated on the left side of the auditorium, irrespective of whether I see with the right eye or the left eye. So that is how you would sort of interpret in your day-to-day clinical practice. So it affects your visual field, but it does not affect an individual eye. So that is how the vision may get affected in case of stroke. So it could cause vision disturbance, speech disturbance, sensory symptoms, hemiparesis, hemianesthesia, or if your posterior circulation. Now, brain is supplied by three main vessels, two carotid, one vertebrobascular. So vertebrobascular supply your brain stem as well as the cerebellum as well as the occipital cortex. So if your brain stem vertebrobascular is affected, all of a sudden one may develop severe vertigo, and then may develop double vision, might start vomiting, and then might find difficult to walk because the patient is with ataxic. So in that type of a situation, then you know that it's the posterior circulation that may have got affected. Or in otherwise, say if you bleed all of a sudden to brain, you may not be able to elicit any of these symptoms, and patient might get sudden severe headache, and then he might collapse on ground, and then will be left with headache and might not even regain consciousness. So that patient is with sudden severe hemorrhage, which has affected his consciousness totally and might not regain consciousness. So those are sort of syndromes that the patients may develop following a stroke. So when you examine patients with stroke, you need to have scales, that for anything that when we document, there has to be a system. So the scale that we use to examine stroke patient is called NIHSS, National Institute of Health Stroke Scale. So if it is available in the net, one has to practice using NIHSS, and based on that, when we do examine, say if NIHSS is if 0, then no symptoms. If it's a minor stroke, it's 1 to 4. It goes up to 42. So if it's 5 to 15, then moderate stroke. And if it's more than 20, then we know that it is a severe stroke and patient is seriously affected by the stroke. So these are important classifications, gradings that are important for us to communicate as well as to decide on certain forms of management. Then the clinical classification, again, you need to be familiar with. I told you that we have two classifications. One is based on the area, the blood vessel that is affected. This is a clinical classification that you do not based on a particular investigation. So we have 3 blood vessels: anterior circulation stroke, posterior circulation stroke. So 2 carotids are anterior circulation, and then when vertebrovascular is the posterior circulation. And in addition to that, if your tiny little blood vessels are affected, then you call it, both these anterior circulation, posterior circulation are large vessels. And when your tiny little vessels are affected, capillaries are affected, I told you, then you get what we call lacunar stroke. So the lacunar syndrome is the other entity. So these are the 3 entities that we have in our clinical classification called OCSP classification, Oxfordshire Community Stroke Project classification. In the OCSP classification, which is the anterior circulation stroke, which is the most common form of stroke, you get the clinical symptoms that would appear would be hemiparesis, hemisensory loss, visual hemianopia or loss of vision of one eye, or dysphasia. I have described all these things, how it get affected in clinical practice within my lecture. Then in case of posterior circulation, it supplies the occipital lobe, I told you. So the patient is with isolated hemianopia, then you know that it's occipital lobe because it's isolated. The brain stem features or cerebellar involvement, then you know that is posterior circulation. Whereas in case of lacunar syndrome, your speech is not affected, your vision is not affected, general sphincters are also not affected. It's pure motor weakness or pure sensory or motor sensory only. And sometimes it's just little ataxic or little dysarthria and Kamsian syndrome and mild attacks. So they are with better prognosis because they are small vessels are affected. So that's lacunar syndrome. So one should be able to clinically classify patient because we decide treatment modalities based on what vessel and what type of a stroke is it. So the diagnosis, I have already told you that it's a clinical diagnosis that we make, and depending on the description of acute onset of clinical features of focal pathology. And the confirmation or exclusion of hemorrhage is by imaging. And imaging, when you develop a stroke is the highest emergency that I know, because every minute counts millions of cerebral cells that are important for function. Therefore, you immediately have to rush the patient, and the time duration that is allowed in a best of center once the patient has reached the hospital is 20 minutes. So you need to do stroke CT scan and everything within 20 minutes, and you need to consider the stroke mimics. Sometimes the person with diabetes has taken the drugs and then has skipped the meal, end up with hypoglycemia, and then could develop some of the symptoms suggestive of stroke. And sometimes it may be a focal seizure, and sometimes other metabolic syndromes like hyperviscosity and hyperglycemia, very high blood sugar, and they develop hyperviscosity, and sometimes migraine with aura may cause stroke mimics, and that's a place that you need to be a little careful. Right. And then when you do a CT scan, and you know that when you do CTs, we have two ways to do CTs. One is CT with contrast and CT without contrast. So if you suspect a stroke, all the time what you do is CT without contrast. Whereas if you suspect a tumor or abscess, you need to do the CT scan with contrast. So now when you do CT without contrast, if you see this, this is the place your middle cerebral takeoff, from the internal capsule, and this is middle cerebral. So if you see this, when you do a CT scan in acute stroke, then you know that this is a thrombus in the middle cerebral at the M1 segment, in the very proximal part of the middle cerebral. And then if you see that, you know this is going to be a worse stroke, but we describe it as malignant MCA, or hyperdense MCA, middle cerebral artery. So if this happens, then you know that he is going to end up with a disastrous stroke over the next 6 hours, and that's going to cause sort of irreparable damage for that brain. So in today's context, say if you are in a place where facilities are available, immediately this patient should undergo clot retrieval or removal of the thrombus if the patient has reached the hospital within the stipulated time period. That's generally maybe 6 hours. So this is an important sign that one needs to be familiar with. We describe it as hyperdense MCA. And then when your immediate CT would be normal, but little by little, gradually patients would appear changes. So you need to train your eyes to recognize those changes. Now you see that the haziness that is appearing, and here's the caudate and in the internal capsule in the normal side, but you now here you see that the whole thing is blurred, and the structures the distinctly cannot be sort of differentiated. And then over about next 24 hours, you would see further changes appearing, and then they be further categorized. To classify the CT changes, we further categorize them into M1, into M3, and the internal capsule, caudate, lentiform nucleus, likewise, so that we further could classify them. So why we need to go for CT scan is CT is available, cheap, and it does it fulfills what we generally are interested in. So that what is necessary is to differentiate hemorrhage from an infarction, and this is how it would happen over the next few days. This is a lacunar infarct. This is how when one of the capillaries are affected, you will see that tiny little infarcts, and those are lacunar infarcts. And here is another infarct in the lentiform nucleus, and here is again a fresh infarct, not within hours, but maybe about 24 hours old. And this is how a middle cerebral artery infarct would appear. You see that whole area is now infarcted. Again, a fresh infarct, it's not an old infarct. This is an old infarct. Now, you see, when an old infarct is there would be atrophy of tissues, so that this becomes hyperdense, and this wall will get dragged into that infarct side, so that ventricle might become a little bigger than the other side. So this is how an old infarct appears on the CT scan. This is how a hemorrhage. I told you that hemorrhage could easily be detected. This is not hemorrhage, it is calcification. This is calcification on the skull, right? So that also appear as thick black, but this is not calcification, it's hemorrhage. So you should be able to recognize a hemorrhage very easily. I told you that we have two classifications. One is clinical classification. Based on your clinical features, you call it that total anterior, partial anterior, to posterior, and lacunar syndrome. But here is another classification, what we call toast classification, based on the etiology. Why one developed the stroke. So if it was a large artery atherosclerosis, that was responsible for development of stroke, more often it is the carotid that is responsible for development of stroke, then we call it. I mean, this classification you could use after clinical evaluation. I mean, say once you have done all investigation, you could group that patient into whether it is large artery atherosclerosis or whether it is cardioembolism, whether it is small vessel occlusion, and these are the three main reasons why one develops stroke. So while once you have, then there are other rare causes of strokes, like what are those? Antiphospholipid syndrome, systemic lupus erythematosus, vasculitis. So there are other rare causes of stroke. So when you develop a stroke, there are three important components for development of stroke. One is the constituents of the blood, the other is the blood vessel wall, and the other is the heart. So if you develop a stroke, one of these has to get affected. It's either problem with the blood vessel or blood or from the heart. So if once, I mean, there are rare causes. So those we decide as stroke of other determined etiology. And once you have thoroughly investigated, if you still have failed to find the reason, that does not mean that the patient does not have a reason. What it means is that you did not find the reason. So then you end up as the entity called stroke of undetermined etiology. So these are the 5 categories of stroke based on etiology that we use. It's described as toast classification. So risk factors for stroke and TIA. Now, when we talk on this thing, we decide based on risk factors. So I told you the most recent is atherosclerosis, and there are risk factors for atherosclerosis, and we divide them into 2 categories, non-modifiable and modifiable risk factors. Now, age, sex, aging is a non-modifiable risk factor. Male sex is non-modifiable risk factor, race, geography, and genetic risk factors. So those are non-modifiable risk factors. Whereas the modifiable risk factors are the more important ones. What are the modifiable risk factors? The disease-related and lifestyle-related. So disease-related, I mean, if we get back to lifestyle-related first, and you know that smoking, alcohol, unhealthy diet, physical inactivity, they 5 are the main leading factors that would lead to many others. I mean, that is why we say that many could be prevented. Say these 4 were addressed: smoking, alcohol. Many of you, I think that you do not have these 2 risk factors, but unhealthy diet and physical inactivity, the prevalence is rampant. So if you address these 2, so that individually, by the time that you reach your 30, 40, you would be healthy, and that is to address unhealthy diet and physical inactivity, which is there among all students. So with these 4 would lead to obesity, high blood pressure, diabetes, hyperlipidemia, and they all together would lead to ischemic heart disease. In addition to that, the contraceptive pills, hormone replacement, and drug abuse are other known risk factors. So risk factors for cerebral hemorrhage are first, second, third. I told you high blood pressure, antiplatelet, anticoagulant drugs, alcohol, substance abuse, amyloid angiopathy. These are mainly for hemorrhages. So it's important that you recognize risk factors. All right. 10:42. So now if we describe transient ischemic attacks, if your symptoms settle within a very short period, and if you'd have done the investigation, then I told you that you could recognize nowadays, based on technology, we could recognize even ischemic tissue. And if we have done on time, infarcted cells, of course, we definitely could recognize. So now, when we manage patients with transient ischemic attack, and how would you know that it's a transient ischemic attack? Patient would describe your symptoms, and now when you see the patient, it's all the time a retrospective diagnosis because patient has completely improved. So if the patient has completely improved, that's the best time that you could help that patient, because once the cells are infarcted, you know that there is nothing that we could do. So see, when you come across a patient with transient ischemic attack, then you should be able to risk stratify them based on this ABCD2 score, and it would predict 2 days risk of stroke. So now what are the entities that are categorized in ABCD2? Age, if more than 60 years, then you give 1 mark. B, blood pressure, if more than 140/90, then you give 1 mark. Clinical symptoms of focal weakness, then you give 2 marks, or speech impairment without weakness, then you give 1 mark. And duration, if symptoms lasted more than 60 minutes, then you give 2 marks. If 10 to 59 minutes, you give 1 mark. If less than 10 minutes, no marks. And then if patient has diabetes, then you give 1 mark. So then the full score would be 7. And if patient is 6 to 7, score is 6 to 7, the risk is high. The risk of developing a full-blown stroke over next 2 days is about 8%. And then if its score is 4 to 5, the risk is about 4%. And if it's less than 0 to 3, it is 1%. So how does it help you in your day-to-day clinical practice? So if you are an OPD doctor, then when you do the ABCD2 score, if the score is more than 4, then you know that he carries a high risk of developing a stroke. All patients with TIA has to be evaluated by a specialist over the next 14 days, because our attempt is to minimize the risk of developing a full-blown stroke. So now it is not possible for a specialist to see all TIAs. So in our setting, if that score is more than 4, then it's perfectly all right for you to admit that patient, because there are many things that you could reverse and to bring down the risk of developing the stroke over the next 48 hours. Now, the MRIs have done so much of a difference for management of stroke. This is a normal MRI scan that I'm trying to show you. In an MRI, you have an extremely strong magnetic field which align H plus nuclei and develop these varying films with varying resolutions. So we described this as the T2 film, where the CSF would appear white, and this is a T1 film where you see that CSF is black, and then this is MRA, where we do more often with contrast, and then this is a flare scan. It's another different resolution. So there are many resolutions that during MRIs the radiologist could adapt to show or to elicit many important features that are important or relevant for us to in managing patients. So when we suspect a person to have an acute stroke, or when the patient comes to you saying that I had weakness 2 hours ago and then now it has settled, so you just do not know whether patient is genuine, whether patient had psychological symptoms, or then we know that if the patient had symptoms at least more than an hour, there has to be infarcted tissue, then what we need to do is to request for an MRI with the entity called diffusion weighted image. The resolution, we call it DW image. So when we do MRI with DW image, very easily we could, even if there is few infarcted cells, the DW images would pick them up. The word that we use to describe is it lights up. So it lights up against the background so clear, and this is the infarcted cells. So the patient has completely improved, but patient is left with infarcted cells. So these are actually not TIAs, but those are strokes. That's why I said that MRIs differentiate ischemia from infarctions. So the once MRI is done on time, if there are changes of this nature, then they end up as strokes but not TIAs. But if they have done the MRI on time, and then if MRI is normal, then you know that the patient had a TIA but not a stroke. So this is here I'm trying to show you MRIs done in patients who have had strokes, and this is MRI of same infarct. The first one is the MRA. Now all these investigations, both the CT and MRI, have the facility to trace the vascular tree. We could do CT angiograms as well as MR angiograms. Now here's a situation where we have done the MR angiogram, and you see that the occlusion of the middle cerebral artery, and along with that, this is a DW image that where we will show that acutely infarcted cell, and then this is the FLAIR image. Now FLAIR image shows this at any swollen or that the fluid. I mean, but the FLAIR is fluid attenuated immersion recovery. So this does not differentiate the hemorrhage from an infarct. So this does not differentiate this does not differentiate acute infarction from a chronic infarction. Whereas this, yes, this clearly shows acute infarction. So that is why it's important for you to do a DW image. So this is a patient with FLAIR, DW image, and MRA. So this image is important for us in situations where we want to see the extent of acute injury to the brain. Again, it's the same thing. Now here is a CT scan showing a lacunar infarct. Here is the MRI with a FLAIR. This does not differentiate old infarct from a fresh infarct. And here is the MRI with the DW image. This shows fresh infarct, and this would last only for about 7 days. So you need to do MRI early if you want to see that change, acute infarct. Now this MRI with DW image, what does it show? It shows hyperintensity areas on both sides. You see one here and one here, right? So as you see that, and then in this cortex, then as you see that, you know that it has to be a common source. So likely that this patient has a cardiac source of thromboembolism because he has infarctions on both sides. Management of TIA. So now I have told you that TIA is the most important time that we could help patients. So what the high-risk TIA should be admitted, that I already have told you. Refer to a specialist clinic. All the others have to be referred to a specialist clinic. They need attention of the specialist. Exclude stroke mimics, that you need to do that. Then they should undergo, I mean, if you are working in best of centers with facilities, all facilities, they should undergo imaging, MRI with diffusion weighted image of brain and intracranial vessels and extracranial intracranial vessels, right? So that is the place that if you have. If you do not have MRI facility, in some of them, it may be the source of thromboembolism could be from the carotid. So carotid we could trace, there are a few ways that we could investigate carotid. How do you investigate? We could do an ultrasound over the carotid, we call it carotid duplex. So if you have facility, we could trace with MRA, you could do carotid MR angiogram of neck vessels. If otherwise, you could do a carotid duplex, ultrasound of the carotid. And then you need to control all vascular risk factors. So immediately you need to, if the blood sugar is about 300, 400, immediately you could achieve the ideal control of blood pressure, blood sugar, right? All vascular, you could give high dose of statins, atorvastatin 40 milligrams we generally use. And then blood pressure, you immediately would not bring down the blood pressure to ideal, but then you could lower a little and then gradually you could reduce the blood pressure. The patient should be commenced, and so you need to, once you have done the CT, if the patient is not with the hemorrhage, you could give a loading dose of antiplatelets. Now, how would you give the loading dose of antiplatelets? You could give clopidogrel 300 milligrams stat and 300 milligrams of aspirin. That is the loading dose of antiplatelet, 300 milligram of clopidogrel plus 300 milligram of aspirin. And then you give 75 milligrams of clopidogrel, that is one tablet is 75 milligrams, and 75 milligrams of aspirin together daily for another 3 weeks. Generally, we do not give dual antiplatelets together for long term, but we give dual antiplatelets only for 3 weeks. The data is only for 3 weeks. And then after that, you need to continue them on a single antiplatelet long term to minimize the risk of developing a stroke. And then for patients with significant carotid stenosis, I told you that we could evaluate carotid. We could evaluate carotid either by a MRA or by a duplex study. If when you do evaluate carotid with a duplex, if they say that there is carotid stenosis, in the relevant site that the patient develops symptoms, you evaluate only that site. So if in the relevant site that you evaluate, if you develop right hemiparesis, your symptomatic carotid is the left carotid. So when you do a carotid duplex on that left carotid, if there is stenosis, then you should be able to grade that stenosis, whether it is more than 70%, whether it is more than 99%, that is complete occlusion, or whether it is less than 50%. Likewise, you should be able to grade the stenosis. So if the first stroke itself is a complete middle cerebral artery occlusion, and if that damage has already happened in an established stroke, by doing carotid studies and by sending the patient on surgery, you gain nothing because the damage has already happened. But if the first attack was a TIA or a minor stroke, then once you do the carotid studies, and if it is with 70 to 99% stenosis, then you could send that patient to remove that thrombus from the carotid. And that procedure is called endarterectomy. So you either could send the patient for endarterectomy, or nowadays you could use angioplasty. Stenting also can be done. Angioplasty followed by stenting also could be done. But generally, stenting, they both are sort of with equal effectivity. Stenting generally is kept for people who are not fit for surgery. And then if you want to get the benefits of these procedures, they have to be evaluated fairly fast, and then the surgery has to be offered the patient within first 2 weeks itself. Right, so I have told you special things that you do. One is loading dose of carotid, then is investigating the symptomatic carotid, loading dose of antiplatelets, then investigating the symptomatic carotid, and then again there is if the person is with cardioembolism. The very first case that I discussed, the case scenario was with cardioembolism, atrial fibrillation. So you need to, if the patient is with large artery disease, indicating that the patient had bigger thrombus, or a cortical infarct indicating that it's a bigger thrombus, then you need to be careful to see that whether the patient is with cardioembolism. So if patient is with cardioembolism, then you can't remove the heart, no. So you need to put them on long-term blood thinners. So but the blood thinner that we use is anticoagulants. So you need to start them on anticoagulants. What we use is warfarin, right? But then there are novel oral anticoagulants, what we call NOACs, that is still not much being introduced to Sri Lanka, and is not much popular here in Sri Lanka. we still use the old warfarin. So you need to start them on long-term anticoagulants if there is a reason or a source of cardioembolism. It may be atrial fibrillation, it may be mitral stenosis, or it may be the patient has undergone MVR, mitral valve replacement. Then the cardioembolism with atrial fibrillation or rheumatic valvular heart disease, you need to add them on warfarin. And if patient is, once you have done all these things, if you still do not find the reason, then it is a cryptogenic stroke. And then if it's a cryptogenic stroke, then you could do what we call TOE, the transesophageal echocardiogram. Patient had a stroke and you do not know why patient developed the stroke, and patient continue to have the same reason for development of stroke. He carries the risk of developing the stroke or a transient ischemic attack. So you could get the patient to swallow the probe, the ultrasound probe with camera, and look at the heart from a different view from behind, and then you might see there is a patent foramen ovale. PF4 is present in about 20% of normal people, so you do not close PF4s in all patients. But if PF4 is in a cryptogenic stroke, and it may be that you could consider closing PF4. Right. So any questions? If there are any questions, you now post questions. You could put the questions in the chat box if you have questions. Can you hear me? Right. But madam, what did you say about atorvastatin in TIA? Can you repeat again? Now, the main risk factors, we said that disease-based risk factors for stroke are diabetes, high blood pressure, high cholesterol, right, and hypertension, diabetes, high cholesterol. So for all stroke patients, immediately we give them a loading dose of atorvastatin. We give about 40 milligrams of atorvastatin immediately. For all, we do not wait until you get the lipid profile reports, because we know that we anyway have to lower their LDL levels. So statins have been shown to have a plaque stabilizing effect as well. So all stroke patients are on long-term statins. So that's what I said, but madam, atorvastatin in TIA. So TIA also management is secondary prevention. So you lower their LDL levels and you immediately give them 40 milligrams of atorvastatin. ABCD2 classification, what does it mean by duration? Question is not clear. Madam, in ABCD2 rule of thrombolysis, ABCD2, now thrombolysis is a different thing. Thrombolysis is for management of infarction. We did not discuss thrombolysis yet. Sorry, no. I missed two questions. Sorry. Madam, in ABCD2 classification, what does it mean by duration? Right. Now, ABCD2 is used only for patients with transient ischemic attacks. So for you to do ABCD2 classification, patients should have improved. And then the A is for age more than 60. You give 1 mark. B is blood pressure. You give 1 mark if blood pressure is high. C is clinical features. The D, that's what it's asking. C is clinical features. If person has hemiparesis, you give 2 marks. And if it's only speech, you give 1 mark. D is duration. Symptoms lasted more than 60 minutes, you give 2 marks. If symptoms lasted for 10 minutes to 60 minutes, you give 1 mark. If symptoms lasted less than 10 minutes, you give no marks. That's the question. And D2 is, the second D is diabetes, 1 mark. Right. what is the role of thrombolysis in stroke management. That we still did not do. So that will be done only tomorrow. We still did not discuss on management of stroke. We may discuss only management of transient ischemic attacks. Transient ischemic attack is when you see the patient, if the person is normal, how you manage, we discuss. We still did not discuss how you manage a stroke. Wait, questions are moving on. Madam, if patient had TIA with the ABCD score less than 3, what are the advices should be given to the patient? So definitely now you need to direct that patient to a specialist. You could ask the person, you could still give the loading dose of statin. You could give that patient, I mean, if it's milder symptoms, that is then only 3, and then the risk of hemorrhage is very low, you should start the patient on antiplatelets. If the pressure is there, you could prescribe drugs for pressure, and you could advise on diet, you could advise on exercise, and then you could ask the patient to get the lipid profile done. You could ask the patient to get the blood sugar done. You could ask the patient to get the ECG done and basic investigations done, and then to see the specialist as soon as possible. Madam, did you explain a bit on dysphasia occurring in stroke? Could you explain a bit on dysphasia occurring in stroke? But I said that it is not on stroke if the dysphasia is speech. Dysphasia is a speech disturbance. I described on speech disturbances. There are 3 types of speech disturbances: dysarthria, dysphonia, and dysphasia. Then I said that in stroke, the speech could get affected in 2 ways, either by dysarthria or dysphasia. Then I said dysarthria may occur if you are with a brainstem pathology, or if you are with the cerebral pathology, then there will be a problem in articulation. Dysphasia, you use the term only if your speech area of the brain is affected. So speech area is in the cortex of the dominant hemisphere. And then it is divided into Wernicke's area and the Broca's area. Wernicke's area is for reception or understanding, and the Broca's area is for expression or motor speech. And if both are affected, then you call it global dysphasia. So in either case, if you have, irrespective of whether you have Wernicke's aphasia or Broca's aphasia, then you know that it is the cortex that is affected. And as you get the cortex involvement, then it's a large vessel that is affected. So that's what I mean. Dysphasia is a very important symptom that we need to recognize in management of stroke, because it helps you to locate where the pathology is. Can you explain again about the differences in FLAIR and DW MRIs? So in majority of MRI films, when you check for, you would see a FLAIR image. FLAIR image shows you the structures based on amount of water, the fluid in it. It is fluid attenuated inverted recovery time. In a normal MRI, when you look at, you see that FLAIR image. It does not differentiate acute cerebral injury. Whereas if you want to see acute cerebral injury, when you ask for MRI, you need to specifically ask for a DW image. Unless you ask for, they do not do a DW image. So if you suspect acute stroke, all the time we say to do a DW image, and DW image only would show you acute cerebral injury. Madam, is there any use of GTN in the first appearance of symptoms of stroke at home? No, GTN would not help, because GTN would immediately drop your blood pressure. So that is not anything that we recommend. So GTN is not going to help. If the patient has already GTN at home, GTN is for ischemic heart disease. GTN has nothing to do with stroke. Madam, if a patient develops TIA once, should he be on drug treatment lifelong? Yes. The reason is, I mean, even before you develop TIA. Now, for cardiovascular disease, what we treat is for risk of developing a stroke. Before they develop symptoms, you treat them to minimize the risk of developing a stroke. So before you develop a stroke, the patient is with high blood pressure, say your parents, they may not have developed a heart attack, they may not have developed a stroke, but many of them are taking drug treatment for high blood pressure and for cholesterol and for diabetes, isn't it? So they take those drugs lifelong. So once you have developed a TIA, then you get into the highest risk category. The patients who have had stroke and myocardial infarctions, they are in the highest risk category for development of another attack. So having a TIA also is similar to a minor stroke. So he is in the highest risk category. So you need to do everything possible to minimize the risk of development of a stroke. So generally, I mean, you can't remove reasons, so you can't remove blood pressure, you can't remove aging, you can't remove genetics. So you could keep cholesterol under control. You could keep blood pressure under control, but that is by lifelong treatment, yes. Madam, can we differentiate infarction and ischemia by both CT and MRI? CT scan does not show ischemia. If changes are there in the CT scan, then the cells are infarcted. So if in a case of a stroke, if you see CT changes, then you know that that patient is not. Now tomorrow I'll be discussing with you on management of stroke. No, then I will be discussing on thrombolysis therapy, the window of opportunity and so on. No? So when you do a CT scan, if you see changes on the CT scan, then we know that the patient is not within that therapeutic window, because CT changes take time to appear, and when CT changes appear, those cells are infarcted. CT does not show ischemic cells, whereas MRI shows ischemic cells. MRI DW image shows infarcted cells. But MRI has other special techniques which I did not show you, called diffusion weighted MRI, that is DW, and the perfusion weighted MRI. So the perfusion and the mismatch of those, the MRI could do two varieties of films called diffusion weighted and perfusion weighted images. So the diffusion weighted image shows infarcted cells, perfusion weighted would show both ischemic and infarcted cells. So the difference would show us the ischemic cells. So I think I answered all questions. Right. That's all. Those are the questions. No more questions. So thank you very much. Thank you for your patient attention. When I started the lecture, wait. When I started the lecture, there were 150 students. Now there are only 96 students. Thank you.
Thank you, madam.
Thank you, madam. Thank you, madam.